So it's 8:30. We'll start the program. Very good evening to everyone. Welcome everyone for this webinar on an interesting topic, metamorphosis of surgical training. Before we start, I request our chairman, Narayan Chandra Hebsur, to do the welcome address. Hebsur, sir.
Thank you, Chandru. I welcome all the dignitaries today for this wonderful program, Metamorphosis. And moderator is Dr. Rajan, sir. Dr. Sreekar is the speaker. I request you to please begin the session. Kindly enjoy the session. It's going to be interesting. Thank you.
So before we start, this session is moderated by none other than a well-known surgeon, Dr.C S RAJAN, sir, jewel of ASI and the past chairman of Kscasi ASI. Request Rajan, sir, to give the initial remarks and start the programs. Please, Rajan.
Yeah. Good evening, everybody, and very many thanks for nominating me to be a moderator for this very interesting topic. Before I even say anything, I'd like to just clarify and explain what metamorphosis is. Metamorphosis is usually a biological term and is used to show or designate a change in structure or form in an organism. Metamorphosis. Like the larva becomes a butterfly or a tadpole becomes a frog. Those are changes of metamorphosis. But I looked up the dictionary and saw that any marked or more or less abrupt change can be adopted to the term of metamorphosis. And that is why Dr. Sreekar, our speaker, has chosen how our surgical training has undergone a vast change, a big change in how we were doing it, how we are doing it, and how we are going to be doing it. I'm very happy to introduce our speaker, Dr. Sreekar Agumbe Pai. He is one of those dynamic academics that we have in the city of Bangalore. Associate Professor of Surgery and head of a unit at MS Ramaiah Medical College with over 21 years of teaching experience. He did his MS in 2003 and followed that up with the MRCP from Edinburgh in 2006. He has about 20 publications and 2 chapters written in books. He is one of those forward-thinking chaps, and I'm so happy he's bringing us along with him in his forward movement on describing how the changes in surgical education are going to take place. Dr. Sreekar is married to Dr. Sangeeta. They have 2 sons, and I see a big, long road of a successful career in front of him. And I think we should encourage him by giving him our full hearing and support for this talk. As usual, the rules of webinar for this meet also will go on in that we will allow Dr. Sreekar to finish his whole presentation. Please put your comments in the chat box and questions too. And we'll spend some 10 to 15 minutes on question and answers at the end. I request Dr. Chandrashekar and Dr. Hebsur to have a look on those chat boxes, just in case I miss any of the questions or comments that are coming. Without further delay, let us go on to Dr. Sreekar. It's all yours.
Sir, am I audible, sir?
Yes, you are.
Yeah. Sir, thank you for those kind words. I really appreciate your introduction. Thank you for the esteemed panelists from the Karnataka State Chapter. You are our mentors and have been mentoring for several years. So it's my humble request that I'm so proud that I could have some time of some of your time to present this metamorphosis of surgical training, which is very close to my heart, because at heart I want to be a teacher from the day I have stepped into the surgical field. So I always wanted to have a field wherein I can talk about this. So I really thank the esteemed office bearers to give me an opportunity to come in front of such a beautiful organization and my senior colleagues and my colleagues and my friends. So let me start with the presentation. Is the presentation seen, sir?
Yeah.
Okay.
Make it full screen now.
Yes, sir. Yes, we'll do that. On away.
It's not visible. Sreekar?
Yes, sir. Yes, sir. I just wanted to go to the desktop. That's why I was searching.
Sreekar, just share the screen again and one of us can help you
Yes,
go
sir.
full
Yes, sir.
screen.
No, I'm just
Share.
opening the PowerPoint. It's just I
You
had
had
opened
opened
it
it.
wrong. Yeah, it is opening, sir.
I think you loaded your videos into the PowerPoint.
Yes, that's why it is taking some time.
Take some time.
Yes, sir.
Share screen now.
Yes, sir. We'll do that.
Press F5. You got it.
You can see now, sir. Yeah.
Yes.
Thank you.
Yeah, fine. It's perfect.
So the topic would be the metamorphosis of surgical training. So I would like to make it as most. So most of our training for the surgical thing. So objectives of this particular discussion is a brief history along with the domains of learning and methodology of learning and advances of technology incorporated into surgical training and what we are seeing in the future. So what are we looking at? In the past, we had what is called as the apprenticeship model. So the basic concept was see one, do one, and teach one. And from the current era to the future era, we have a huge amount of technological advances, which I'm going to discuss about. Let us not forget the very foundation of surgical training has been by our great Shushruta and the Halstadian model, William Halsted. Understanding the nature of learning. Surgery, unlike other branches of medicine, is highly skill-based science. So we have the three skill-based science. One is the affective domain, the cognitive domain, and the psychomotor domain. The psychomotor domain is the one which is most important in surgery. However, let us not forget that the affective domain and the cognitive domain are equally important. We need to have a lot of public relationship that we have to maintain in the affective domain, and also we should be updating ourselves in the cognitive domain. The three learning skills that we as surgeons need to know are visual, auditory, and the kinesthetic. For us, the main thing again comes as kinesthetic. That's a hands-on activity through which we learn maximum. Also, the visual aid helps in getting us into the proper methodology. Teaching surgical skills, as adopted by Hartley et al., is we have the 5 steps of learning surgical skills. So we need to start with activation of the prior knowledge of the student, and the next step is the teacher demonstrate skill without commentary, and teacher demonstrates skill with commentary, and followed by that the teacher demonstrates a skill with student commentary, and finally the student practices on his own. So this is adopted to make the student understand the surgical skills in the best methodology. So the Bloom's taxonomy is the one which gives us an understanding regarding how the person learns. In the initial stage, as Sir was telling, the cocoon stage is the basis of remembering, followed by that understanding, and finally creative. So the experts in the surgical fields are the ones who are creating. They are beyond the learning stage to the giving stage. So that will be the possibility of final interest in training. Constitution of the ideal surgeon and the teacher. So what one should know what are the personal attributes of the doctor with the teaching responsibilities. So what are the attributes that we can see? The enthusiasm for the specialty, commitment, 100% commitment both to teaching and learning, sensitivity and responsiveness to the educational needs, and the promotion of personal attitudes and professional attitudes and values, understanding the principles of education as applied to methodology. Also, one should know to improve the knowledge, one should involve into research activities and develop both as a doctor and teacher. So you can understand that it is illimitable the amount of requirement for a teacher, and in surgical training it is one of the most important requirement. The qualities of ideal surgeon are a good clinician, needs to manage well, communicator and a team player, leader and team player, health advocate and scholar and teacher. The society always wants the surgeon to be the epitome of development and give knowledge and cater to the needs of the society. So this self-actualization is the final potential that the surgeon tries to endeavor. Who are the real stakeholders? Let us not forget, whatever we are trying to train ourselves, whatever we are trying to do, whom are we doing it for? So there are several stakeholders. The main key point is the surgical patient, who is the primary stakeholder, who looks at you at a point wherein he has no other further thing. That's why we are always called the ones who are the gods who are walking, because we are the ones who will go near the patient when they are sick. So the surgeon, the healthcare facility and the trainee are also the stakeholders, the funding authority, society at large. Society is very important to in the upbringing of the surgeon. They cannot remove our rights, and they should protect our rights when we are trying to go further in the treatment of the patients and also getting trained in the treatment of the patient. So the patient finally wants to be treated safely, efficiently, with the minimal complications and round the clock cover with the least cost or even no cost. The challenges of the training system. So the first residency system, which is credited, is by William Halstead, and the residents had long period of apprenticeship. Opportunities were given only to the indigent patients, so non-paying patients, and trainees were given graded responsibility. The trainee wants to receive good training for his long hours of work and needs adequate opportunity to hone his skills to able to be perform operations safely and expeditiously. Whereas the paying patients will refuse to participate in this training program. So there is a set of people who will be paying, whether they are paying or not. They will not want to be at the mercy of trainee doctors. So this is the problem which happened, that there was a lot of anger with the people and the public in terms of being used as guinea pigs for the training work. So this brought about a lot of limelight by the press, media, and also a lot of public, which was crying against this kind of model, that non-paying patients are being used for training purposes. In India, the challenge is that 80% of the healthcare is yet with the private sector, and 67% of the patients are paying out of the pockets. So it is very challenging for training in our country. These challenges have to be addressed by learning in a non-stressful environment, and also the student may require repetitive training for learning and honing his or her skills. So what do we understand by surgical training? So the surgical training refers to the standardized and high quality preparation that the surgeons undergo before performing the surgery. It involves patient selection, preparation, the actual surgery, post-operative care, and effective communication. So the need of the hour is virtual reality-based training, which is used as an additional tool to enhance surgical training and address the limitations of traditional mentoring. So these enables trainees to gain experience before treating the actual patient, and also provides alternative methods to acquire skills with the flexibility of training. Say a patient comes with a murmur in the heart, even 100 students can listen to them. But if a patient requires a suturing, he will not be able to be treated by 100 surgeons. He can be treated only by one surgeon. So we need that flexibility in training, opportunity to incorporate new surgical technologies and innovations in the surgical repertoire, and provides the opportunity to trainees to learn from the consequences of their mistake, enables practice of crisis, resource management, and team training outside of emergencies. As Sir was telling, he likes cricket. Even for entering a match, the cricketer or batsman has to go into the nets for practice. But in surgical training, we expect the student to be knowing to do the suturing on day one. Will he be able to do it? So we have a lot of newer technologies which are being incorporated, beginning with low fidelity stimulators to high fidelity stimulators, virtual reality, augmented reality, animal models, cadaveric models, robotic training, 3D printing, artificial intelligence, and the list goes on. But let us go through each one of it as possible. So the methodology is, for all this, there should be a methodology of learning. So it is called the curriculum-based surgical education. So we need to know the need, what do we need to train the student, and to appropriately use the simulator model, develop a curriculum with specific learning objectives, have a mentor in place, do the performance and the assessment of the performance. The feedback is given by the mentor to the trainee, regarding how he or her have performed, and they can repeat the same for improvement. So one of the most important foundation courses is the basic surgical skill course, with a lot of mentoring by experienced staff. This is a key learning milestone for the student, beautifully taken by our surgical society, both at state and state level and national, as well as our city level. So we have annual CSP programs for the surgical postgraduates. As you can see here, a lot of mentoring activities, and you can see the familiar faces who have helped a lot in developing. So here we have the very important low fidelity simulation by endotrainer, which is used as one of the primary methods of training. The next is one of the high fidelity. We have what is called as lab mentor and simulator of for endoscopy and bronchoscopy training. So endoscopy and bronchoscopy training. So these are training which can be used for understanding the augmenting their training needs. So here we have a lab at our center. So are there in many other centers in India. So the next is what we call as the virtual reality. So virtual reality is one which has which we had seen in movies, which is called as Matrix, wherein the hero enters a room and he gets trained for the karate and everything within no time. So similarly, we never thought that we will have these kind of things developed into surgical training. So virtual reality is one which is completely virtual. The virtual reality users are controlled by the system. It requires a headset device and it's a fictional reality. Whereas an augmented reality, it uses the real world setting and they can control their presence in the real world, and it can be accessed by smartphones and virtual and record and real world. So here we have the virtual reality, wherein they are in a virtual world and are able to perform certain activities which okay. One second, sir. I'll just. Are you able to hear, sir?
Yes, Sreekar, we are with you.
Yeah. There were a lot of comments regarding the connectivity issue. That's why. So the virtual reality is the one which helps in doing things without in anything available, that is in the virtual world. Whereas augmented reality, the augmented reality is the real world. It is augmented. So for an example, if there's a bone tumor, one replicates it with the CT scan photo, CT scan pictures which are available, and does the surgery virtually. So it augments what is real. The other one, the animal model training, which is in vogue in few centers, usually on pigs, which are very close to human. There are a lot of limitations due to certain issues, certain legal issues. Developed is the cadaver training hands-on. This is basic application of the natural body training. They are performed on cadavers, mainly donated for scientific purposes. It's one of the highest order donation for the humans. So it requires a dedicated setup and high level maintenance. So we have performed the first very first.
Sorry, Dr. Speaker, I have to interfere. Your audio is gone off and is very irregular.
Yes, sir.
The chance of correcting it, please.
Yeah, yes, sir.
Dr. Rajgopal Shenoy says it's due to the rains.
Yes, sir.
You can switch off your video.
Yeah, that will be better. So we conducted the very first cadaveric training on in 2012, which was facilitated because of a very dedicated faculty, as you can see for the program, and they have mentored us for training the various surgeons across India. So here you can see some of the videos when the students are actually performing on the cadaver. These are gallbladder surgeries which they may have performed otherwise with no fees. They would have had to perform these under the vigilance of senior surgeons. But here they can perform without much worry. As you can see, these were all training for the students in the cadaver training, and very senior faculty were present who performed, who were mentoring the students for learning. So here they have performed intracorporeal knotting on the laparoscopic models, and here we have you can hear Dr. Om Tantriya's voice. They are performing laparoscopic inguinal hernia on cadaver. So here, as you can see, again, Lakshman sir, Pin Bhatia sir, they had come for the very first program, along with Shivram sir and Rajan sir, and many more. So here you can see the demonstration of the cadaveric training for students on another. So there was a mentor who was performing the laparoscopic surgery on the cadaver, which was transmitted to them, and they were learning it. The next, of course, is the robotic surgery. The robotic surgery has reinvented surgery with high precision surgery. Getting trained is very difficult and expensive too, but we can have what is called as simulator training for robotics as well as cadaveric training. So surgery also, the live surgery can be performed with mentor or proctor. So here we can see robotic training for a simulation for the robotic training. So they can perform the activities on which they are going to do on the robot as a simulator base And further to that, they can perform the same with cadavers. So once they are able to get the dexterity of the movements, they'll be allowed to do the performance of the surgery. The other very important entity in surgical field is the artificial intelligence. What is this artificial intelligence? It's the incorporation of highly advanced software program into the, So it is a involvement of highly developed software into the training of surgeons. So it's called personalized training. The personalized learning for trainee strength or weaknesses, simulation-based training, which mimic the real-world scenarios, predictive modeling, that is to identify surgical complications before they occur, and augmented reality, which makes much more accurate decisions and improve patients' outcome. The other one is the remote training, which is training from a remote place to the surgical training. Integration with robotics. Integration with robotics. So it promises to redefine.
Audio not heard?
Yes, sir. Yes, sir. 1 second. Are you able to hear me now?
No.
1 second. Now, sir, are you able to hear me?
Yes.
Oh, okay. I think. So the other thing is the integration with robotics, which promises to redefine the surgical procedures. Tools such as ChatGPT can integrate a lot of literature and create new papers. So these are the involvement of artificial intelligence in surgical training. The next is the telesurgery. So remote surgery. So person is somewhere and the surgery happens somewhere. However, there are difficulty in the challenges and limitations are that who will be responsible for the outcomes for the patient. So it is not yet in vogue. The last but not the least is the 3D printing technology. So here, the University of Manchester Medical Center developed a 3D printing to create artificial organs back in 2016. The 3D printer gets organs very similar with similar pattern recreated, like the heart, like the liver, the kidney. So what can happen is if there is a tumor in the kidney, what can be done is the tumor is reproduced using the CT scan, MRI scan, and a new model is built from the scan available, and the surgeon performs the surgery on this particular 3D model to allow the person to be confident to do it on the patient. So this is the kind of technology we are going to enter into in the coming years. So this there are several training centers that are developing for the 3D printing. So it is again very expensive. So one should learn that, understand that these newer technologies are extremely expensive for a day-to-day use, and they need the students need to spend quite a hefty amount to learn it. However, over a period of time, when the usage becomes more and more, these are going to be incorporated into the surgical training in more quicker manner. So here you can see a developed heart, which can be used for training of the surgeons. Last but not the least, we should never forget the mentorship program. So the important thing is pairing of a mentor with a mentee. So mentor is the one who is having advanced knowledge and is able to guide his mentee for performing several activities. It will be a 24-hour care, and which goes not only by the professional, but even their knowledge, skills, and attitude. So all of it is going to be incorporated in trying to develop and hone the skills of a developing surgeon. So this requires the human touch, which is not available in all these newer technologies. So it goes back again to the Halstedian model, wherein we need to understand that surgeons are humans. So they require that human touch to understand and learn. It also helps in developing the leadership, and also there is a active feedback which comes into the program and allows the person to know how him or her how they are developing in their programs. The future ahead, it is, one should understand that there is no only human, there is no only technology. It's the cooperation of the humans with the technology which are the ones for the road ahead. So it is important that one should be aware of the developments in the surgical technology and adapt to the new technology. If you are not adapting, you will perish. So one should realize what are the requirements that are needed to develop on these advanced tools in order to enhance the surgical skills. Even a successful surgeon will be requiring a mentor to come back and try to give ideas to develop the current state of surgical skills that that person is having. So it is not that we have learned. We are always learning throughout our life, and we have to be learners even at advanced states of our surgical skills. So here, mentoring the surgeons, I always feel that conferences and skill development programs are always important to improve on our skills on a regular basis. And we have had a conference which was very good in order to know what we are missing out and what we can improve on. So I would like to conclude my talk by profusely thanking the Karnataka Society office bearers to give me an opportunity to talk in front of such an esteemed organization and esteemed surgeons. Thank you. I would like to conclude my talk now, sir.
Thank you very, Dr. Sreekar.
Thank you, sir.
As we could all have experienced, technology is far from perfect, and we were also having in this simple webinar audio issues and lack of clarity when videos are playing. So it is a long way still before we can use advanced technology and tools to incorporate into safe learning.
Yes, sir.
So that is an important thing. Dr. Harsha has raised some very valid points.
Yes, sir.
He says his mentor is now YouTube. He looks at YouTube videos
Yes, sir.
and learns to do the surgery. How
So,
comfortable will you be when you realize your surgeon is a YouTube trained surgeon? What is your opinion?
it is, I think Harsha sir is in the self-actualization mode. So he's able to perform the surgery by watching it. But definitely, one should realize his or her limitations. If they're able to perform within those limitations, definitely YouTube will be a mentor on its own. However, it is learned from expert surgeons. The YouTube channel, what Dr. Harsha may be uh, uh, trying to get to, is performed by expert surgeons who will give a lot of experience in the thoughts of doing this YouTube videos. So definitely, I mean, he can't tell to the patient that I have learned from YouTube, but definitely it is a chance that one can learn from sitting at a remote place, a particular surgery, which may require more intrinsic movements. So they can learn from leaders in those fields.
Well, what we can say is there were a time when we used to have operative textbooks open
Yes,
and
sir.
somebody reading the steps to us while we
Yes,
were
sir.
doing an unusual surgery. So if you advance that to modern technology, you have the YouTubes to help us. The problem is credentialing. How
Yes,
would
sir.
you give the rights to the surgeon to do that surgery? Now, that is the thing that we all have to put our heads together and get a definite method of certifying the fitness or the ability of a surgeon to perform certain surgeries. So that credentialing part of it should go parallel to the development of technology and the adaptation of technology. It is the validation of the tools to be safe for surgical or for use on students who will then put it use on patients that we need to be doing parallelly. So it is a little bit of an administrative challenge to be able to get the right balance between ability and licensing.
Yes, sir. I think he will need the mentorship when he is performing very advanced surgeries, if he's not done it before. That possibly the problem also for him would be that they may not have mentors at the right time for doing it. So definitely validation is an important tool, but resource also comes into quite a important challenging aspect for this, sir. That is my view, sir.
I'm also happy
Rajan
to
sir.
know that our audience, sorry, yes?
Rajan sir, there are a lot of questions which are similar. I think so you can take it together, I think so, sir.
Yeah,
Yes.
And there are a lot of things which are understood.
Yeah. So there again, Dr. Manjunath Kotanavar has also very rightly said, better to adapt to the newer advancements like YouTube and get going. Dr. Narshek has also said that judgment comes by following mentors and should not only go by YouTube. Okay.
Yes,
So
sir.
here I am going to put forward a proposal of a surgical coach. Every
Yes, sir.
tennis player has a coach, every cricketer has a coach, there's a bowling coach, there's a batting coach. Why not a surgical coach? A seniorish person with years of experience should be there as a mentor and as a standing by person while a younger surgeon performs the surgery.
Performs.
So that is a very valid, useful method that I think should be pushed and adopted more. I tried to push the idea to local surgeons here in Bangalore, but nobody took me up on it. And so the vast experience of senior surgeons should not be left alone, but must be used to go through this metamorphosis time of surgical training.
Kindly, somebody is talking. Can you mute, please?
Chandru, I think
Listening, sir.
somebody must mute these people. Thank you.
Yes, sir. I'm there, sir.
Yes, sir, working on it, sir.
Sir, I am Dr. Harsha talking.
Yes, sir.
Yes, sir.
Sir, actually, in our surgical training, definitely looking at the mentor, how he is doing, and we are going to learn the basic surgeries. Now, we can't expect.
Kindly mute, please. Ravi, thank you.
Sir, we can't expect all the surgeries to be displayed to us, one thing. Second thing, all the surgeries to be given as a first-hand experience for us. If that is the case, is there anything like not to consider the virtual platform of visualization and then learning on your own? Is it very dangerous to perform, or do you agree with going ahead with complex procedures after learning the basic procedures?
I have a slight problem in that the YouTube material is not standardized. You very often, the surgeries that come up are the first time surgeries of a new surgeon who is very proud of what he has done, and he puts it up on the YouTube. Do others who see it follow that? I do not think it is safe.
It's not evidence-based.
No,
Most
complex surgeries should not be done just by watching. They should assist many surgeries and then do independently. Just watching
But
and
in
doing, I don't
today's
think.
world of large number of trainees and less number of patients, as pointed out by Dr. Rajgopal Shenoy, where is that poor new surgeon going to get the exposure?
But
No,
we should not put the patient's life into risk, sir. Just watching the
I agree.
YouTube and doing complex surgeries.
Yeah.
Sir, Rajan sir, you
Yeah.
brought up.
Will we undergo that surgery from a surgeon who has learned from the YouTube?
That is a question he asked. I think, yeah.
Shankar, you are saying something, please.
Sir, there is a, JCHST, that is Joint Committee for Higher Surgical Training in England, which credentials people, the surgeons to perform certain surgeries. I think the surgical for Association of Surgeons of Karnataka, for example, and then maybe Association of Surgeons of India should take the responsibility of credentialing these surgeons. There should be a methodology to credential. Only then they can operate on this. So then what happens is there is some degree of control and some degree of credibility to the people who are doing these procedures. I don't know how whether it is practically possible, but I think that model should probably be explored by people like you who are in the power, and it is be difficult, but it is something that you can think of.
Shankar and Rajan sir, regarding this, in fact, we are discussing this on accreditation board, and Dr. Lakshman sir has already done a lot of homework on this. Dr. Lakshman sir, please talk about it, sir.
It's difficult to summarize it in a short period, but I would like to make 2 points to my esteemed colleagues here. A, doing training or imparting mentoring and training on private patients is completely acceptable. Across the world, there is absolutely nothing wrong, simply based on very clear evidence that if the consultant is standing next to the trainee, no harm is done to the patient. It is as safe as if the consultant did all the operation by himself. That's the first point. I understand the limited material available, but whatever is available, what is actually holding mentoring and practical training back is not just the lack of patience, but the lack of the attitudes towards mentoring. Our seniors don't scrub up and stand next to the patient to train the trainee.
Yes.
I'm glad to say that we have been doing it for the last 25 years. And my colleagues, I know for a fact in Sagar are doing it. I can't speak of others because I have not seen them. I'm sure many other centers are doing it as well. But it has to be a lot more than what is going on. So the real message I want to drive home is that mentoring is the real solution for all surgical training problems. and that every single surgeon, private or otherwise, medical college or otherwise, must take it upon himself as his responsibility to train at least a few students through, actual mentoring, standing next to them. How can the lack of patience be addressed? Our medical college people should have the broad-mindedness. I'm not blaming anybody, I'm not criticizing anybody, but they must be broad-minded to allow their students to go out of the college to private centers which has willing trainers or mentors. And once this is not going to happen overnight. It hasn't happened for the last 25 years. It may take another 5-10 years for it to develop. But once we develop the culture of sharing all our knowledge, private and medical colleges and government, the whole system must become one with the unified purpose of training good surgeons. It is not utopia. It is not just imagination. If all of us put our minds to it, it can be done. If we do it, things will definitely improve. Thank you.
Thank you, Dr. Lakshan. Very, very useful inputs. What I would also like to add that I train surgeons with a single personal motive that in case I needed a chest drain, it should be done properly on me. Or if I need a colonic resection, my surgeon who will mostly be my student should do it properly. So I have that interest also as a selfish motive to keep training and getting people better. The main thing is the will of the mentor. And I have had the sad situation of seeing seniors say, Ayoyo, avun bandidana OTಗೆ ಕಳಿಸ್ಬಿಡು, operation ನಿಲ್ಲಿಸ್ಬಿಡಿ. They don't want to share and show what they're doing. If such is the attitude, then it's very difficult to get past. But medicine is learned from a lot of what we see, followed by what we do. So that is a part of mentoring that needs to be done. And the use of technology to move it up is a boon for us today. It is helping. But how much we are going to do it or not, we don't know. Dr. Ravi Shankar, tell me.
Yeah, sir, there is another thing there is something called record of in-training assessment in England, where every year there is, the trainee sits with their however many professor or consultant they work with, and the consultant will give you his feedback of the year's work, what he has done, what he is happy with, what he is not happy with. And the trainee also is allowed to rate the particular job that he has done, the consultants themselves. For example, did they give him enough opportunities? Did they give him, did they discuss cases with him in the clinic, whatever? And then this goes into the training. There is a day which is assigned where all the training of that particular region, the regional coordinator and everybody will be there. So you are asked the question not only about your surgical training, about the research that you have done for that year and other interpersonal relations. Have you got any problems with communication with your boss or your juniors, your nursing staff, all of these things. And then also, what is the way forward for the next year? What are your goals for next year? What do you want to do? So that kind of in a limited way that has to be done so that the student has a goal. You're not just going from one year to another without proper goals and without proper aims as to how are you going to develop as a surgeon in the following year. I think that again is a food for thought. I think I don't know how to implement it, but it is something that should be considered.
Yeah,
Dr.
point well
Rajagopal
taken.
sir.
Yeah, Shenoy sir, Dr. Shenoy.
Good evening. I just a little bit of difference way of thinking about the topic. Topic is metamorphosis. So it is not about I train or you train or XYZ training, number one. It's not about the hospital or any individual perception per se. What I try to understand is, firstly, congratulations to Dr. Sreekar Pai, number one.
Thank you, sir. Thank you, sir.
You have given a matured, meticulously planned, I can make out a medical education departmental, values in your talk. I remember not less than some 20 years back, you taking me to show the cadaver lab.
Yes, sir. Yes, sir.
What indirectly, what I'm trying to tell is whether it's a mentee or a mentor, there should be some kind of enthusiasm, some kind of energy and empathy in all, in whichever way you train. So instead of using the word metamorphosis, I would be happy that changes. It's a
Yes,
change,
sir.
basically a change.
Yes, sir.
See, Shushruta's forehead flapper, it still remains the same forehead flap.
Same.
Correct. So it is not metamorphosis. The training program requires changes related to the situation. Necessity is mother of invention. That's all
Yes,
it is.
sir.
So
Yes,
whether we have in less patients here, whether somebody has more patients, ultimate remains is the relationship between the mentor, mentee, and how you learn. So coming back to the technological things, we have spoken about so many artificial and so many things. We have to only repeated reminders to everyone that one should not become the slaves of these things, because cost adds up. Cost adds up. So instead of using all these words, whether YouTube, one person has done first time, last time, 10 times, 15 times, it is not the issue. Is not that. Issue is about you are able to take up the technological things by seeing, remembering better. Yes, I studied anatomy 18 months. I said this in Mysore. But then remember, I have seen much better anatomy now with the laparoscopes, with the magnification of the views, whichever has happened. So this is the key point which somebody has to take it in your talk. Number one. Number two, yes, doing it in a cadaver, as somebody has asked this question, that can you do first time? Yes, you have done so many in the cadaver lab, Kohli. I remember you showing me that mainly for knee joint and I think gynec surgeries.
Yes, sir.
Long back, correct?
Yes,
So
sir. Yes,
these
sir.
are the things which will help in a long run. So let, at the end of the day, human touch remain. Most important thing. Let human touch remain. Thank you very much.
Yes.
Thank you, Dr. Rajagopal. Very mature and valid and true practical aspects of this whole transition phase that we are having between a student training and mentorship. So thank you, sir. Very valuable tips.
Sir,
Interpretation.
Rajan sir, kindly give your moderator remarks and then we can close the session, sir.
Yeah.
Because there are too many things to be discussed.
Yeah, if you start, we won't sleep. So I think we've had an interesting hour so far. Dr. Sreekar, thank you very much for your
Thank you, sir. Thank you.
preparation and the delivery of very important points that open our eyes towards the future of surgical training. For all of us, it was a learning time and also made us think, because there are plenty of topics and chat that came up of various aspects of mind working while the talk was going on. And that is what we want in a lecture. It's not just blindly receiving everything, but not only
Yes, sir.
receiving, we analyze and we say it. So that way, I think this purpose has been achieved. Thank you once again, Dr. Sreekar. Thank
Sir,
Space
yes.
Chapter for allowing us to put our heads together in the advances of surgical training. Today, it is 3D printing and what is called as operation prototype planning that is going
Yes,
to
sir.
come into the future within the next 10 years. And that prototype planning is you get an MRI or a CT scan or you get any imaging modality. The technology is there to reproduce that anatomy of that patient for you to see virtually on a screen and practice the surgical maneuvers the evening or the day before the surgery and then go and do the surgery. Like today, we had a nice demonstration of the Moynihan hump. Now, if there was operation prototype planning on that case, we would have been ready for that hump when we went straight away and would have been more aware that this thing is there lurking underneath. So like that, there is advances which will be to the benefit of the patient, which will need us to change our methods of training so that the new methods are not seen as harmful, but seen as benefits. Thank you very much, everybody. Good night, sweet dreams, and we'll meet again at the next webinar.
Good
Thank you,
night.
Dr.
Sir,
Hebsur. Thank
moderating
you, Dr.
and
Chandrashekar.
Dr. Sreekar sir, it was excellent talk. We really
Thank you, sir.
enjoyed every moment. There were too many things, too many thoughts coming up. Everybody were involved and everybody has too many issues which need to be addressed. I think
Yes,
so.
sir.
Change is constant and we need to
Yes,
adapt
sir.
to the change and go ahead. I
Yes, sir.
request Chandrashekar to give the vote of thanks. Before that, I would like to make one announcement. Our journal, which was started by us for this year, Karnataka Journal of Surgery, Chief Editor Rajan sir was the mentor and who started this journey, and Dr. Venkatesh has become a chief editor now, and it is already open. I request all of you to please support by joining and giving the articles of real good interest, which will help us to produce, come out with this journal as soon as possible. This journal is going to be published by the end of September. So I request all of you to please send your articles as early as possible so that they can be published. Thank you.
Yes, sir. If there are no questions, we'll conclude the session. Before that, one point I would like to mention is, whenever you talk about surgical training, always we think of with respect to the skills. But unfortunately, when we see at the end of the residency or 3 years postgraduate program, we don't assess skills of the postgraduate. It's only an objective assessment or theoretical assessment where we are going to clear them. So hopefully we'll see in future that somewhere we are going to get this type of assessment where the skills of the postgraduates can be assessed before we can give a degree, or we can certify that this person is going to practice. So this is one view. Yes, sir, Rajan, sir, anything?
Yeah, they are. The DNB people have now started introducing a basic surgical skills station, and every candidate has to go into that station and perform some kind of a surgical task, and it'll be supervised and evaluated. So that is going to be incorporated into the final general surgical examination practical day very shortly. So that's coming up. I hope it becomes universal.
Yes, sir. And behalf of KCSI, I would like to thank today's speaker, Dr. Sreekar Agumbe Pai, for
Thank
an
you, sir.
informative talk. And as usual, moderator was rocking, Dr. C S RAJAN, sir. Thank you very much, sir. I thank the executive committee members of KCSI, all the members of KCSI who are present today, and had a good discussion. Thank you, everyone. Thank you, one and all. Good night.
Thanks, sir. Thank you.
Good night, everyone, sir.
Yes, sir.
Thank you. Thank you, everyone.